All right, so let's go ahead and get started. As you see, we only have 2 weeks to go over health and physical fitness. And it's not because I'm trying to rush you, it's because I'm kind of rushing you because there's a lot of stuff to go over in this course because the requirements to be certified require all these different modules. So I'm trying to push them as fast as I can, but also spend enough time also applying some of that knowledge in class as well. So health and physical fitness is the first 2 lectures. Last Tuesday was our first, and this is our second on health and fitness. So we're going to go ahead and get started with that. Next week we'll get more into functional anatomy and training instruction. And then we'll have our first test on the 13th, or the 10th, on a Thursday, okay? Functional anatomy assignment will be due later that weekend. Any questions about the schedule or assignments for Module 1 and 2? So if we look at Module 1 and 2, hopefully by the end of this week, you'll have either reviewed all these PowerPoints and videos on your own to get more clarification. I'm providing some of the video that they provide on their website as a substitute to learning or an added bonus to learning if you didn't purchase any of the materials. But I probably won't be able to go over every single video on that site because it might not have enough time. So let's go ahead and finish the rest of that video that we were watching the other day.
Forces. Strength balance relates to the strength ratio of opposing muscle groups across joints throughout the body. Appropriate strength balance allows for proper levels of force output and stabilization within musculature that facilitates joint actions. It is therefore integral to movement proficiency and reducing the risk for injury. For example, an optimal strength balance ratio between the quads and hamstrings should be 3:2. For every 3 units of force production in the quads, the hamstrings should be able to resist at least 2. Someone with a ratio closer to 3:1 will have a greater risk for ligamentous injury at the knee joints. Putting all these pieces together, stability plus strength balance provides greater movement proficiency and a functional kinetic chain. Let's progress by reviewing flexibility and mobility and how they independently impact how well you can move. Flexibility is indicated by the ability of a muscle to move through a full range of motion at a single joint in a single plane, so it is independently measured at specific joints. It impacts joint function, movement efficiency, injury risk, and the presence of chronic pain. Mobility, on the other hand, is the ability to move cooperative body segments through a full, unrestricted range of motion without undesirable changes in biomechanics. Multiple joints are used rather than one. It also examines the impact of muscle fascia tension across body segments. So a key concept here is that flexibility is not synonymous with mobility.
Okay, another way to remember that is one thing we do is, let's say if I'm pulling my knee all the way up to my chest, this would be an example of flexibility, where I'm using a passive means to be flexible, and then mobility would be being able to hold this position actively, okay? Then they're also saying that this would be flexibility, being able to reach overhead. Mobility would be able to reach over my head while I'm still squatting. Because you'll notice that when people squat, they'll drop their arms forward because their lats are really tight. They don't actually have that shoulder mobility, or they cheat by using their lower back. And you'll see people kind of use this stance of walking sometimes because their lower back is just doing a lot of work. It's like you're propping your body on your back. That's also due to poor breathing too, because our diaphragms are actually different on each side. If you didn't know, our right diaphragm has a bigger dome than our left, and when we breathe more on that right side. So we actually tend to bias this right side and get into our right hip more than we do our left hip, okay? Which means our adductors on our right are a little tighter. Our psoas on our left side is a little tighter because it's a little bit bigger. And we also tend to drop our right shoulder and have our left shoulder up. So next time you see people just standing, or even me, you might see me just get in this right stance position. And so people try to correct that by standing up tall, but inside of their body, we're actually asymmetrical. So sometimes people can try to prop themselves like this to try to straighten out their back because they're really like this. So that's kind of going out there with PRI. I don't know if you've ever heard of, anyone ever hear of PRI? Postural Restorative Institute. If you want to know more about asymmetries in breathing and respiration and how your body kind of compensates because of the way we breathe, look into PRI.
We see that presented clearly with the subject here. On the left side, we see he's able to raise his arm directly overhead, indicating good shoulder flexibility. But on the right, we see that single joint flexibility did not translate into functional multi-joint mobility during the overhead squat, as his shoulders have migrated forward into an incorrect position. The overhead squat does not just challenge shoulder flexibility, but rather cooperative shoulder, spine, and hip mobility. Let's now take a look at the final health-related component of fitness, being body composition, as well as related factors such as obesity. Body composition is indicated by the ratio of fat mass to fat-free mass within the body, and is often expressed as a percentage of body fat. High body fat is associated with metabolic dysfunction, systemic inflammation, and various common diseases. There is subcutaneous, visceral, intramuscular, and essential fat in the body.
What do you think the most important fat is?
Visceral?
Essential fat. So essential meaning that it is essential, okay? And basically when we lose all of our body fat, that's the last thing that will go. Then the first thing will be, below the skin. Then you might see it, intramuscular, and then it will become more visceral. And the last thing that will actually burn will be our actual organs.
Now, because body composition looks at the percentage of the body that is currently fat, adding muscle mass will positively impact body composition without even losing any fat. The key concept here is that health is determined by body fat percentage, not just the total quantity of fat. For example, a 200-pound man with 40 pounds of body fat will be assessed having 20% body fat, while a 140-pound woman with the same 40 pounds of fat will be assessed having 28.5% body fat. The woman in this scenario would have a much higher risk for disease and health problems. Obesity is an important term used to indicate an unhealthy quantity of fat mass relative to lean mass or weight. Normal weight obesity is another unhealthy classification indicated by normal weight in relation to population norms, but a high percentage of body fat, also known as skinny fat. Unfortunately, the Centers for Disease Control suggest nearly 35% of U.S. adults qualify as obese based on body mass index.
Those are two really important statistics that might pop up later. They like to use that on their exam, I know that.
And more than 70% of the population is considered at least overweight.
7 out of 10 people are overweight.
To combat the progression of obesity over the lifespan, regular exercise is very important, but proper nutrition is more than half the battle. Dietary factors associated with obesity and health issues include eating excess calories, consuming too much sugar, salt, processed carbohydrates or meat, saturated fat, alcohol, and red meat, and consuming inadequate fruits and veggies.
Who has a bad habit was one of those on there.
Let's continue forward with the performance-related components of fitness, starting with power. Power can be defined as the rate at which work is performed. Training, therefore, focuses on rapid movement and acceleration, rather than the total resistance moved. Development focuses on recruiting type 2 or fast-twitch muscle fibers with greater efficiency. Example activities include Olympic lifts, plyometrics, and weighted jumps or throws. As indicated earlier, power is not just for the young. Remaining powerful over the lifetime equals functional aging, prolonged independence, and a reduced risk for debilitating sarcopenia. Sarcopenia is an issue experienced with older age, indicated by a loss of total skeletal muscle mass, particularly a reduction in fast-twitch muscle fibers, which greatly diminishes function. Of course, when seeking to develop power amongst older adults, appropriate power training modifications must be applied. This will be covered in a later lesson. Let's progress by taking a quick look at speed and agility.
What is the most powerful exercise that requires the most force output? Not weightlifting. Sprint, you said sprint, yeah. So sprint would be the number one way to increase power. So what should athletes probably be doing? Sprints twice a week, 3 to 4 sprints twice a week. That's about it. That's like your hamstring prevention injury cure.
Why is that? Why is sprinting?
Because it requires the most energy, and basically you're training at such a high, when you're producing that much force and you're able to go one step, you're able to reach 5 or 4 feet in the air, that you're using a ton of power. Okay.
I think it was last class or the class before we talked about like if you run for too long, it actually like becomes slower.
Yeah.
So like how long would you want to sprint for twice a week so that you don't become slower?
Well, the person that I follow, when it comes to sprint, they do time 10s. So they'll have like a 10-yard, they'll start 10 yards before they're going to get time for 10 yards. And so they want to know their 10-yard split because they say that you'll increase injury with 40-yard dashes. So that's why they do 10 in, 10-yard. You could do just starting at the 10, or you could do run-in 10s. So twice a week. But you need a really good warm-up to do that. So like foam rolling, stretching, active stretching, dynamic warm-up, motor control. Then you actually want to perform maybe some medicine ball throws before you go out there and sprint, just so that you're primed. Instead of just going out there cold, static stretch and then sprint, I wouldn't recommend that. I'd recommend kind of going through a good warm-up.
Speed is expressed as the time to perform a movement in a single direction, or the rate of positional change over a distance in a measured period of time. It depends on neural recruitment patterns, adequate muscular fitness, stability, dynamic balance, and flexibility.
Now, when I'm in this half kneeling position, what does this look like? A lunge? Sprinting. So that's why this position, when we teach it, is so important. You wouldn't want to run with your hips out, So a lot of these positions that, sometimes we'll train are to get better power and stability in our gait, really. We want to be able to walk, run, throw, and jump more than anything as humans, because that's what we've really been doing for the past thousands of years.
Speed is often considered the most valued measure of performance in sports, hence the saying, strength hurts, but speed kills. But it is also relevant to function, as increased gait speed equals a lower risk for falling and/or fractures among the elderly.
So the better pace you are walking, the less likely you are to fall.
As it relates to the
But
ability
you see
to
people
perform
that kind of
rapid
walk like
horizontal
this,
movements with
probably
changes
more
in
likely to fall than
velocity
someone
and/or
that has a good
direction
gait.
in response to analysis of the environment. It is not synonymous with change of direction proficiency, as it requires both motor and data processing efficiency. True agility is challenged using open skill development. Open skills are motor skills that require reactions to
They probably will ask you this question. They want to know if you know what open and closed skills are, and they're going over that now.
changes in an unpredictable environment, such as juking out an opponent in soccer, while closed skills are motor skills performed in a stable or predictable environment.
basically when you're, dribbling your ball through the court, that's open and closed would be, penalty shot would be close to it. Or
such as making a free throw shot in basketball. Let's now finalize the lesson by covering the last two performance-related components of fitness, balance and coordination. Balance is defined as the ability to manage forces which act to disrupt stability. High balance translates to more efficient movement, posture, and bodily control. It is needed for sport participation, activities of daily living, and to reduce the risk for injuries or falls.
that's why doing things on one leg is important when we're training. We're not always on two legs, because when we're on two legs, we don't have to use our adductors, abductors, we don't have to use our transverse abdominis or our QLs, which are our stabilizer muscles. And so as soon as we go on one leg, we're actually in 3 planes of motion. We're in the sagittal, we're in the frontal because we're using our abductors, and then since we're not rotating, we're using our transverse plane as well. So that's how you get triplanar kind of anatomical positioning, is going on one leg. So all those things are active. And 8% of your body weight is in one leg. So then, that means 64, or what would it be? 16%, yeah, 84% of your body weight is on one leg, as opposed to having 32% on the ground and then the rest above. So that's why unilateral can add all that stuff into your workout. So more bang for your buck.
Balance improvements occur in the nervous system via the development of adequate strength balance, optimal force coupling, and proprioceptor education. Proprioceptors are special organelles located in connective tissue that provide sensory input to the central nervous system via receptors that relay body and positional movement. They essentially allow for physical awareness of bodily positioning, or kinesthetic awareness. The take-home message here is that when the body is challenged by disruptive environments, improved balance and neuromuscular coordination is achieved via increased proprioceptive function. When motor control elements communicate with the brain more effectively, balance greatly improves. Now, coordination ties in with balance and the development of neural efficiency. Coordination can be defined as the ability to control and use multiple body parts and/or senses in a synergistic fashion to perform complex and high-speed motor tasks. Coordination is needed during sport competition, as well as performing daily tasks in a safe manner, and allows a personal training client to perform more complex exercises. It is essentially synonymous with neural efficiency. Nerves and muscles are working together effectively. This concludes the lesson on the health and performance-related components of fitness.
So what would be a task or exercise that would require coordination?
Throwing or catching a ball.
Catching a ball. So what about an exercise? What would be a coordinated exercise, you think?
Maybe wall balls and squat.
Yeah, that's definitely coordination involved there. Okay. What about exercise that requires balance?
Bosu ball.
Oh, the half medicine ball squat.
Half medicine ball squat.
Bosu ball.
Bosu ball. So you're adding instability. Okay.
Box jumps.
Box jumps. Yep. You gotta balance yourself when you land.
One leg squat.
One leg squat. One leg deadlift. Yep. Maybe an uplift from the half kneeling position. Maybe a split squat to row. Balance, coordination a little bit there. So that's all we have on health and performance components of fitness. Again, we have the notes on Canvas for you, and I also have a video of me going over the PowerPoint as well. Okay. The next thing we're going to get into is physical activity and cardiovascular disease. And we'll kind of talk about the main things I think they ask specifically as a certified personal trainer. So we know that physical activity reduces the risk of early death from cardiovascular disease, metabolic syndrome, and obesity. Does anybody know what metabolic syndrome is? The combination of high blood sugar, high blood pressure, and one more thing. What do you think?
Is it high cholesterol?
Yes, I believe so. Various cancers, physical activity reduces, type 2 diabetes, we talked about that. 200,000 deaths annually due to sedentary behaviors. Like we talked about, 1 in 4 people die because of physical inactivity. And heart disease is the leading cause of preventable death in the United States. Who here knows somebody that has passed away from heart disease or a heart attack? Okay, yeah. I never got to meet my grandfather because he had a heart attack in his mid-50s. He was a smoker, drinker, ate saturated fat, salty foods, but at that time they didn't really know all the health information we know now, and they probably would have been able to resuscitate him then with the medicine that we have now. Reducing heart disease risk, probably the most important thing for us. Sometimes we go to the weight room and we lift a lot of weight and we do our cardio and we feel like we're hitting all those boxes, but if we're eating saturated fats, salty or sugary foods, and we have an urge to just pig out a lot, that's going to increase our chance of heart disease. Okay, so if your blood pressure is elevated or your cholesterol or your bad cholesterol is elevated, those are things that we need to try to control through our diet. Okay, and physical activity, obviously, but we need to look at both. So you need to consume a diet in low salt, refined sugars, total fat, saturated fat, and cholesterol. Those are probably the key indicators. You want to make sure that you're eating fresh fruits and vegetables. You're not just having the powders of fruits and vegetables, because we know that you need the fibers, the non-soluble and the soluble fibers, which help poop coagulate and get out the right way, and also help take stuff from your body out with it. Okay, that's why fiber is so important. How many grams of fiber do you think you need per day? What do you think the number is? How many grams of fiber? You can guess.
I have no idea.
Guess. 50? That's a good guess. 100 grams of fiber? Whew. That'd be a lot. I mean, one apple has 4 grams of fiber. So that'd be a lot of apples. Okay. Asparagus got a ton of fiber. 40? Getting closer. Getting warmer. 20? In the middle there, 20 and 40. 35. About 30 to 35. Exercise regularly, 150 minutes per week. I'm sure a lot of us already do that. Avoid excess intake of alcohol and do not smoke. Obviously, alcohol in your 20s, you can get carried away with it. You can end up doing some major damage to your liver if you get fatty liver disease. Okay, and smoking obviously is not going to help you as far as anything goes. Okay, ensure safe use of medications and any over-the-counter drugs. Educate oneself on appropriate stress management and lose weight and body fat if overweight. So if you're overweight, you look at the BMI or you look at your body fat percentage and we're overweight, we got to think of ways or things that we can do that can lower our chance of getting heart disease in the future. Okay, coronary heart disease. So this is what we have here is plaque kind of restricting blood flow. So this is what high blood pressure will look like. There's higher pressure because there's less room to move through, right? So if you have a resting heart rate, it means that one, your heart is beating very strongly and it doesn't need to beat as many beats per minute. And two, you have ways for that blood to transfer without building up pressure, okay? So aerobic training at 60 to 80% VO2 max reduces risk of body fat, blood pressure, systemic inflammation, improved lipid profile. So you have better cholesterol levels when you work out or when you aerobically train at 60 to 80% of your VO2 max. It lowers your ischemia in your heart and it limits risk for blood clots and arrhythmias. blood lipids and cardiovascular disease. So high risk goals. So LDL, we want to be low because that's the bad cholesterol. So LDL, we want to be low. HDL, we want to be high. Okay. So we want our LDL to be under 100, and we want our non-HDL or our HDL to not be over 130, or less than 130. So it can be a little higher than our LDL. Okay. 2 or more risk factors and 10-year risk are 10 to 20%. Okay. Diabetes or chronic kidney disease stages 3 to 4 with no other risk factors. So those are what you're at risk for. You have a 10 to 20% increase in risk if you're over those levels, okay, or under those levels. So moderate risk goals, same goals as high risk. 2 or more risk factors and 10-year risk is less than 10%. And low risk goals is your LDL is under 130 and your HDL is under 160, okay? Physical activity and atherosclerosis is really hard for me to pronounce, but I got it. Arterial lesions caused by hypertension filled with cholesterol deposits or plaque. Aerobic and anaerobic training can reduce risk and progression by reducing your blood pressure and platelet adhesion. Blood lipid and triglyceride management, reduce low-grade inflammation, improving stress management. Okay. Stress management, obviously if we have high stress, we tend to have high blood pressure. So things like aerobic activity, physical activity, and anaerobic activity can reduce that. Stress-induced risk for atherosclerosis. So chronic stress expedites atherosclerosis via hormonal mechanisms. So increase blood cholesterol and triglycerides when you're stressed. So you can actually increase fat and blood cholesterol by being stressed. Excessive platelet adhesion, which is increased risk for blood clots. And stress plus hypertension plus systematic low-grade inflammation equals atherosclerosis. Okay. Physical activity and myocardial ischemia, lack of oxygen due to coronary artery blockage. So that's what myocardial ischemia is, not getting that oxygen in your coronary arteries. Okay, arteries are going away from the heart or toward the heart. Are arteries going away from the heart, or are arteries going toward the heart?
Okay. Away.
Away, yeah. So easy way to remember, arteries are arteries away from the heart, and veins are going toward the heart. So arteries have oxygen or no oxygen? What would you think? Do arteries have more oxygen or less oxygen than veins? More, yeah. So you're going to have more oxygen in your arteries than you do your veins. Your veins are taking deoxygenated blood to your heart. Aerobic exercise exercise reduces risk of, or aerobic exercise reduces risk, improves coronary blood flow, limits cardiac fibrosis or vessel hardening, vascular remodeling, augments O2 delivery, stress management, and reduces risk for arrhythmias or blood clots. Okay, physical activity and thrombosis. Okay, thrombosis is a blood clot capable of causing a heart attack, stroke, or pulmonary embolism. Occur with disruption of atherosclerotic plaque. Okay, so thrombosis, if you hear about that term, just think blood clot and heart attack. Okay, aerobic training reduces this risk by promoting radial arterial diameter, so the arteries are actually bigger in diameter, so more blood flow can go through them, and vasodilation, so they're dilated. It's easier for them to vasodilate. Increased enzyme activity that helps dissolve blood clots when formed. So enzymes actually can dissolve blood clots, but you can only get those from aerobic training. And then decrease platelet adhesion, so you're not going to have that likelihood of that blood clotting in the first place. So basically, physical activity and aerobic training gets things kind of moving, kind of like an oil change for your body when you move. Otherwise, things kind of get gunky and just get stuck there. Okay. Deep vein thrombosis. We may have seen this in some people that you can see their veins kind of coming out through the legs. It occurs throughout the body, but often in the legs. Can be associated with varicose veins and result in post-Fleetlick syndrome. Okay. We'll have to look that one up. I don't think you need to know what that is, though, on the test. Risk factors: obesity, surgery, blood disorders, pregnancy, smoking, family history, older age, bed rest, and meds. So those would be risk factors. You wouldn't want to have either of those things. Physical activity and stroke. Sudden regional brain death from lack of oxygen, usually occurring at either side of the neck. Vascular blockage, ischemic stroke. 80% of cases are ischemic strokes, so that's when there's vascular blockage, can't get up there. And then there may be some arterial ruptures, so that would be called a hemorrhage stroke. So there's two different types of strokes. Can be associated with congestive heart failure. My grandma has congestive heart disease, so she's at high risk of having congestive heart failure. You can reduce the risk by aerobic exercise to lower the blood pressure, by not smoking, and dietary habits that limit inflammation. So like lots of fruits and vegetables. Physical activity and hypertension. So physical activity lowers your blood pressure, which is important because our heart doesn't have to work as hard, and there isn't ways for blood to move that well, right? So primary contributors to cardiovascular disease impacts about 33% of U.S. adults. Aerobic training 3 to 4 days a week for 30 to 60 minutes at 60 to 70% of your VO2 max will lower the blood pressure by 4 to 10, or systolic blood pressure by 4 to 10, and systolic blood pressure by 3 to 8. Reduces resting and submax heart rates, reduces SNS hormone activity, central nervous, oh no, it's not central nervous system. I'll have to figure out what that is, SNS hormone activity. Sometimes they put things on the slide, but like the acronym, but they never went over the acronym yet. I'm like, that would be nice. Improves vasodilation and compliance, improves baroreceptor function, and other factors like diet, obesity, genetic, and stress. So diagnosing hypertension, this is probably one of the slides that they want you to know the most when it comes to hypertension. What you need to know is that a normal blood pressure in the systolic range is less than 120, and systolic is less than 180. So if you were at like 118 over 70, that would be really, really good. If you went to the doctor and your blood pressure is, say, in the 130s or 140s or higher, I mean, if it's higher than 180, you need to consult your doctor immediately, okay? As for the diastolic, if it's higher than 120, that would be way out of range, okay? So we want that systolic and diastolic to be, at these zones here. So normal 120, elevated 120 to 129, and high blood pressure 130 to 139. Has anyone gotten their blood pressure done in a while? Sometimes it's important to find out what your blood pressure is, your resting heart rate is. Some people find out they have heart conditions just due to those two simple tests. So smoking equals disease. So you got a 200 to 400 increase for coronary heart disease. The risk for developing lung cancer increases 25 for men and 25.7-fold for women. Smokers are 12 to 13 times more likely to die from COPD than non-smokers. 2 to 5 years after quitting, your risk for stroke can lower to about equal to a non-smoker. So there is like hope for people that are smoking that are our clients. And then 10 years after quitting, the risk for lung cancer drops by 50%. So you can really lower your risk for cancer by 50%. So common cardiovascular disease medications. So some of your clients might be on some of these medications, and this is sometimes they use these questions in the final certification test to make sure that you know what some of these do, okay? You should be familiar with common medications, and so these would be the most common that are related to cardiovascular disease. So if you have somebody in their 40s, 50s, or 60s who has cardiovascular disease, and you take them through a Part Q or a questionnaire, they're going to probably let you know what medications are on. You need to know what those medications do. So diuretics, they act on the kidneys to prevent reabsorption of water. Okay, beta blockers reduce myocardial vigor by inhibiting the nerve impulse to the heart and blood vessels. You have angiostens converting enzymes, or ACE inhibitors, cause blood vessels to relax by preventing the formation of hormone androgenin, which causes constriction. You have angiotensin and antagonists, which block angiogestin, resulting in the prevention of vasoconstriction. Calcium channel blockers prevent calcium from entering myocardium, reducing contraction. So calcium is really important, and we'll probably go over that later, but calcium is really important in the for reducing contraction, okay? And calcium is stored in our bones. Nervous system inhibitors relax blood vessels by controlling nerve impulses, and vasodilators. So directly open the blood vessels by relaxing muscle in the vessel walls. Okay, so vasodilators open it up a little bit, and all these medications that are medications that you may need to know about if your clients are on them. So it's good to have a good background. I would, if your client comes to you and they're on a medication, you might just ask them, like, how does it make you feel? What does it do to your heart rate? You know, they might know what it does, you know, just as well as you looking up that information too. So make sure that you ask them as well. All right, so it's 10:06. So we're going to do a little bit of movement, and then we're going to come back to lecture. So let's go ahead and find some space out there. So good news, we are going to be getting foam rollers, so we will be able to kind of talk about self-myofascial release, be able to use them in class a little bit. Every class I like to do a little bit of applied learning just to get away from lecture, and also because personal training class, we need to kind of learn how to do some of the workouts and understand functional anatomy. So let's just go over the neck. Okay, let's go ahead and find some space. Make sure you're not able to touch anybody and that you're moving in toward the space and finding room. Okay, so move in a little bit, find some space. So the neck, what does the neck do? Who can describe what the neck can do? Anybody? Describe what the neck can do. Eugene, what can the neck?
I was fixing my mask.
I'm asking you though. So, what can the neck do?
Good question. I don't know.
Okay.
Move your head. Turn your head.
Turn. What do we call that?
Rotation.
Rotate. It can rotate.
Good question.
Pivot. Okay. Rotate. It can flex, and it can extend. Okay. So we're going to go through a neck controlled articular rotation. So we're going to squeeze our fists. We're going to not move anything but our neck. Okay. So when I'm going like this, I don't want to go like this. So I'm going to go flexion, rotation, lateral flexion, extension, rotation, lateral flexion, and flexion. One more circle all the way around. And one way the other, and 2 times the other way. I'm just trying to rotate nice and slowly, nice and controlled. Okay? If you have anybody have any neck issues there, or feel a little bit tighter on one side or the other, what side do you feel tight?
My left. I don't know why. My neck
So
is
so we have closed and open. So if we have a stretch on, say I'm stretching, if my neck is going to the right, if I'm laterally flexing to the right and I have a good stretch here, this would be an open stretch, or open. If I'm going like this and I feel pain here, this is something a little bit more serious than having just a stretch here. So do you feel, when you go to this direction, do you feel it, or do you feel it when you go this way?
just like this way. It's like tight.
Okay, so that's probably
Forward.
or forward. So it's probably just a little tight in there. But if I were to close it like this, that could mean something a little bit more serious. Okay? Because I shouldn't have anything going on here if I'm going in this direction. I should feel a stretch here. I shouldn't feel anything here. Okay, so that would be a little bit more serious. Okay, what about the glenohumeral joint? Touch your glenohumeral joint. Yeah, glenohumeral joint is your shoulder joint. Okay, it's a ball and socket joint. Okay, what does our glenohumeral joint do? Let's go ahead and get in the half kneeling position. Hips are forward. Don't let your hips go out. Your knee is over your heel. So it's not like this and it's not like this. Okay? Your knee is under your back hip and your foot is behind your knee. Your foot isn't going in and it's not going out. Okay? I know there's a lot of points of contact here. Okay? I don't want to be flexing like this and I don't want to be extending like this. I want to be right in the middle, neutral spine here. Okay? If this is ever too much for you, you can go down to your knees or you can get out of this position. So whatever foot is forward, let's just go ahead and put your left foot forward. We're going to bring our right arm up, thumb back. Okay? What did we just do with the shoulder? What's this called? Shoulder flexion. Okay, so we're in shoulder flexion. We're going to internally rotate the shoulder so that we rotate and the thumb will go forward. As we internally rotate, we're going to go out. Now we're out. What is this called? Shoulder what? Abduction. Yep. We're going to internally rotate so that the pinky is forward, thumb is back. And now we're where? Shoulder what? Starts with an A. Adduction. So now we're adducted. Now we're going to go into shoulder what? Extension. External rotating the shoulder so the thumb goes back and up to flexion across the body. Where are we at now? Shoulder what? Horizontal adduction. So you have adduction, horizontal adduction. Okay, let's go ahead and switch. Right foot forward. If that hurt your knee, which I feel my knee a little bit. That's why I asked if we could get like 30 pads, but maybe I'm just getting old. All right, so if you need a pad, we got pads or yoga blocks. We also got those mats too. Let me show you how I would use that. You can get relaxed. If that doesn't feel comfortable, don't worry about it. I don't want you to ever get into a position that you don't want to stay in. Okay, so don't ever think that I'm forcing you to do anything. If you ever just want to observe, that's fine too. You're not going to hurt my feelings. Okay, but if I was using a pad, I might fold it up like this. What do we got? Our left foot forward, and that for me might feel a little better. I don't know, but so let's go ahead. Did we do right before?
Yeah, we're in a right foot forward now.
Okay, I'm losing it. All right, so right foot forward, left shoulder. Where are we at? Shoulder what? Flexion. Okay, let's internally rotate. Okay, all the way to what? Extension. Now where are we? Adduction, ADD. Okay, now we're going into hyperextension. Let's go external rotation. Flexion, horizontal, adduction, and adduction. Okay? Okay, scapula, you can go to kneeling or you can stay where you are. So scapula, what does the scapula do? Where is my scapula? Yeah, my shoulder blades, right? So think of your shoulder blades, they're kind of like your hips, right? They kind of hold in that ball and socket joint, right? So it's really important for stability. The scapula rides on top of your ribs, okay? Okay, so your breathing actually affects your scapula because your scapula is right on top of your ribs, and your ribs expand and detract when you breathe. So it's really important. Your scapula does what, though? What am I doing if I go like this? Okay, I'm not flexing it. What is this called? It's called scapular elevation. Okay? Scapular depression is when I go down. What about when I go back? Scapular retraction. What about when I go forward? Protraction. So what exercises involve protraction and retraction? Pushing and pulling. Anytime I push and pull, I'm using my scapula. Protraction, retraction. Okay? So let's go through a scapular rotation. So I'm gonna, hands are glued, like I got a $100 bill in between my elbow and body. I'm gonna, the rule is you can only go up and down with your fingers. You can't bring your hands off of your body. So I'm gonna go into scapular elevation without bringing my neck forward like a turtle. And I'm gonna go retraction. Keep your arms glued if you can. Depression, protraction, elevation, retraction, depression. Stay at depressed. Retract, in depression, elevation, protraction, depression. Good. Shake it out a little. Elbows. What do the elbows do? Flex. What is this called when I turn my palms face down? Pronation with a P, yep. Okay. Now when I do this, what is this called? Extension. Okay. Palms up. Supination. I'm holding some soup for you. Okay. So let's go ahead and go through an elbow car. So flexion, pronation, extension, supination, flexion. Good. Okay, shake it out. Wrists. Okay. Where am I at now with my wrists? Extension. Try to get the middle fingers face down, not out. Good. Okay. When my pinky goes in toward the midline, is this ulnar deviation or radial deviation? I know I confused you all last time, so I'm probably going to get this wrong forever now. This is ulnar. Now, a way I remember ulna, tibia, and fibula is that the ulna is at the end of the alphabet and the tibia is at the end of the alphabet, and they're both on the medial side of the body. So my ulna and my tibia are at the end of the alphabet, but they're on the inside of my body. That's how I ended up remembering it.
Is the ulna and the tibia both the smaller joint?
So the ulna, the tibia is bigger. Tibia is tougher, it's bigger. Your fibula on the outside is your balance bone. Ulna in radius, if you take two sticks and twist them together, they actually overlap. That's what your forearm does. It overlaps. If you take two sticks and kind of twist them, they kind of overlap. That's what we do when we pronate. I know I've had a client that couldn't pronate. Okay, they couldn't pronate their elbow. So that could be an issue. So wrists, let's go into wrist extension, ulnar deviation, and now we're going to go to, what is this called? Wrist flexion. Good. Let's go radial deviation out and extension. Good, shake it out. All right, let's go into spinal flexion and extension in quadruped. Okay, I say quadruped because that's what it's called, technically speaking. So we're in the hands and knees. Now, a lot of times you're going to see people with their hands out in front of their shoulders. So we want our hands under the shoulders. We want our knees under the hips. And we want our feet behind our knees. So our hands might be a little bit wider than our knees. In this position, we're going to flex the spine and posterior pelvically tilt the hips and flex the neck. So we're in spinal flexion. This is a really good place to breathe in. So we're going to take an inhale through the nose, hold it, and then blow out the mouth, pierce lips. Hold it at the bottom of your exhale. Inhale. Fill up the back ribs. Hold it. And exhale. Now from here, we're going to go into spinal extension. So I'm going to drop the belly, bring the head up. I'm in spinal extension now. I don't need to try to overextend. I'm going to take a couple inhales and exhales here. Inhale, exhale, inhale, exhale. Okay, then we can go back to flexion, and then back to extension, and just go at your own pace for about 5 rounds. Just go at your own pace. Okay, now that's one way. Stuart McGill, who's one of the most renowned back pain specialists, he likes this exercise for his clients. There's 2 ways I've seen it done, is the way we just did it, and then you can also go into segmenting the spine. So I can go in a flex spine, and then I can try to control each vertebrae. Okay? So I can assess what vertebrae can't move. Okay? So if I'm going like this, and I'm flexed, and then I don't move anything in my lower back, and I just go like that, that means I don't have any movement going on in that lower back area of flexion and extension. Okay? So let's go ahead and try segmentation. So I'm going to go into flexion, and then I'm going to posterior pelvically tilt first, and then try to go 1 vertebrae at a time. And then I'm going to drop my head first, bring my upper shoulders toward the wall, and then posteriorly tuck. So try to see if you can segment your spine. If you're really good, you can watch a tennis ball slowly roll down or up your back. Okay? All right, let's move to the hip. Let's do a sideline hip car. So you can do these in the quadruped, but we can also do them sideline. So just got in a nice position on your side here. Okay, I'm going to bring my knee to my elbow. So what did I just do with my hip here? What is this called? Hip what? Hip flexion. Okay, now when I go like this, what is this called? Abduction. Okay. And external rotation. Okay, from here, I want a 90-degree angle with the knee. Now, I just want to internally rotate. So the foot's going to go toward the back, and then I'm going to go into extension, and then down. So I'm in hip extension, knee on knee. So knee is on knee. Then I'm going to go back to extension, abduction, and all the way to flexion. Okay, let's try the other side. So left knee to left elbow, hip flexion, hip abduction, and external rotation. Now I'm going to internally rotate by drawing that big circle with my knee, and then knee touches my opposite knee. I'm going to kick back into extension, open up into external rotation, and go all the way to flexion. Good. Okay? Let's move on to our knee. Okay, so we're going to go ahead and wrap our arms underneath. The book will just say that we just have flexion and extension of the knee, but there is a little bit of rotation in that knee as well. It's called internal and external tibial rotation. Okay, it's not something you need to know for the exam or anything, but just know that it can pivot like this. So I'm going to grab underneath, turn out, extend, turn in, flex down. So turn out, extension of the knee, turn in, flexion of the knee. Okay, let's try the other side. Turn out, extend, turn in, flex. Turn out, extend, turn in, flex. Good. Okay, for the toes, or the ankle, we have different ways that we talk about moving the ankle. First is, what am I in right now? Pointed toe. I just say pointed toe, and I say flex toe. But what does this mean, pointed toe?
Extension.
Not extension. It is, we are, you could say flexion and extension, but they have to make it a little bit more complicated than that. So what would I call this? Plantar flexion. So it seems like that would be extension, but we call it plantar flexion, and this would be dorsiflexion. So you got plantar flexion, if you're planting your foot down, and then dorsiflexion. Okay? Now, when my foot goes in, when my medial foot opens up, what is that called? If I open up my foot like that. If I'm standing up and I go like this, what's that called? Okay, is it inversion or eversion?
Inversion.
Inversion. Okay, eversion is when my inside of my foot drops in. Eversion. Why? Because everyone on the outside can see it. That's how I remember eversion. Eversion, everyone can see it when I go like that. Okay, inversion. I can see it on the inside. So we can go through a circle. So we're going to start in plantar flexion. Okay, then we're going to go draw a circle. So we're at, let's just pretend we're at 6 o'clock. 6 o'clock at the bottom of the clock. We're going to turn into 9 o'clock. Okay, all the way up to dorsiflexion to 12 o'clock. Now all the way to 3 o'clock. All the way down. And then one circle all the way around the other way. Good. Let's switch. Start in plantar flexion. We're going to rotate to a 9 o'clock. All the way to 12 o'clock. All the way around to 1, 3, all the way around to 6. And then rotate the other way. 6, all the way around to 12. All the way around back to 6 o'clock. Good. Okay. So that was kind of a little bit of just what we call controlled articular rotation. Just rotate. Very simple movements that anyone can do. So if you're looking for really easy exercises for maybe your adult populations to do before workouts, those cars are pretty good to do as well for those older clients. Okay, the adductor stretch. So this, if it bothers you, you don't have to do this, but I'm going to show you an adductor stretch. Okay, what are the muscles in the adductors? We talked about this last class.
Isn't there like 4 of them?
Yep.
I forgot.
Well, there's some that kind of cross in and out, but who can name one of the adductor muscles? Three of them start with adductor. So we have adductor magnus, brevis, and longus. Okay? Magnus is a little meatier, longus has more tendon, and brevis is the smaller one of those. Okay? So magnus bigger, more meaty. Magnus is meaty, and tendon, and the longus is a little bit more tendon. Okay? What about the real inside? What's my most medial muscle? Starts with a G. Gracilis. What about the muscle that crosses my hip to my knee? That is my sartorius, like an S. Or backward S, whatever you want to call it. Okay? There's those main muscles. Okay? So to target those muscles, what I'm going to do is I'm going to set up with my hips apart. So my hip, what is that called if I do that? Hip what? Hip abduction. Abduction. So abduction, like you're getting abducted by an alien, you know, you're going all, you know, your legs go out, everything goes out. That's how I think of abduction. So we're going to abduct in the hands and knees position first. Now this might just be a stretch for you. Okay? Now again, if that's too much on your knees or you need some more support, go like this. Okay? I'm going to plantar flex my toes or my ankles. So we are in dorsiflex, try to plantar flex. So kind of point your toes. If that doesn't work, don't worry about it. Okay? From here, I can just rock on my exhale back. Okay? If that is too much, just go in a little bit more, okay? But for the adductor rock, I'm going to abduct one leg so my foot is facing forward. If my knee is bent like this, I might need to reposition myself. But what I want to do is try to get as low as I can here. Now don't copy me if you're not going to get down this way. Just try to set up the best way you can. And we want to see if we can get the outside of that foot down as well. And then from here, I want a straight spine. Inhale, and then exhale on my way back. back to center. Try the other side. Now, if this is hurting, don't do it. Just observe. Just kind of wait. If anything causes pain, I don't want you to do it. Same thing here. I'm going to try to sit up with a nice straight back, and then exhale my way back. And come back up. Okay, so that would be called an adductor rock or adductor stretch. Okay, we've done the half kneeling stretch. We did the Spider-Man stretch. We can do a piriformis stretch, which is one from NCSF. So we're going to go to the back, cross the leg over. I'm sure you may have done this one before. We're going to take the back of our hamstring, dorsiflex both ankles, and pull toward the chest with your back flat, and hold here for 3 inhales, 3 exhales. And we want to try to make sure that our foot is totally across the knee. We don't want our heel or ankle on our femur. Take 3 inhales, 3 exhales. Don't bring your upper back off the ground. Don't worry about that. And then go ahead and switch side. So this would be a piriformis muscle, which is in between the medius and maximus of the glute. And this is responsible for some people's some hip pain. So sometimes they might want to stretch or roll on the piriformis before they work out. Let's go ahead and come back up. Quick, simple, another adductor stretch. If you weren't able to get into that adductor rock, what I would ask the client to do is probably go against a wall. I think wall stretches are the best for people with the least amount of flexibility. So if you ever want to get next to a wall, it's going to help you immediately. Okay. And if we're not relaxed, we can't really stretch because our nervous system is tightening up because it doesn't trust us in that position. So the more relaxed you can get in your stretches, the better. If you feel like you're like, the whole time, then you're not going to ever get that range of motion because you're not able to relax there. Okay, so that's important to find ways to relax in your stretches as well. So this would just be the straddle stretch. Okay, another way you can go and do a bear, they call this a bear stretch. So bend the knees at 90, feet are out. You can press those knees with the elbows here, and we want to try to find a 90-degree with our hips, with our knees here. So try to come out a little wider if you can. Good. Okay, and then pulling yourself in for this stretch. Okay. This would be, this is just you see this a lot, I don't really tend to use this that much. I don't even think it's in the NCSF, this stretch, but you'll see a lot of people using it. You might feel it in your back, or you might feel it in your hamstring. We did the 90-90 last week, okay? What other areas do you want to go over before we go back to our desks? Any other stretches or areas that you're thinking about that we haven't talked about yet?
I guess like back to the neck, we were talking about how it can be tight on one side, like maybe like right here, like where you carry stress.
Okay.
Or look back.
Yeah, I think what would be good would be using the foam rollers to target some of the trap muscles. I wouldn't recommend let's stretch our necks and because I don't, as a group instructor, I wouldn't want to focus on neck rotation, and I wouldn't even want you to really focus on it that much. I want you to maybe think chin tuck. So one of McGill's top 3 exercises for spinal stability, and he's one of the most renowned back experts, is where you lay on your back and your hands are underneath your spine and one leg is straight. And so from here, what I would do is take an inhale, exhale, bring my chin off the ground and tuck my chin. So I'm not like this, I'm kind of tucking my chin. Hold for about 6 to 8 seconds, and then come back down, come back up. And that's going to be a core, believe it or not, exercise, and that's also going to probably strengthen the neck, which might help. I probably wouldn't recommend mobility exercises for someone's neck. Just like I wouldn't recommend someone needing more rotation of the lower spine Just the same reason why I wouldn't want you to increase rotation of your knees, because those are supposed to be stable. So that's why I would think stability exercises over mobility exercises for the neck. The diagonal reach, we'll do this one before. Did we do the diagonal reach last class? Okay, so this is another good core exercise, and then we'll do the side plank. So go to the hands and knees quadruped. I don't want you flexing or extending your spine. I want you to find a neutral spine. Hands are underneath your shoulders. Knees are underneath your hips. So feet a little bit wider. Yep, good, good. From here, without compensating with the spine, so not going like this, I want to see you go reach, extend, and hold without moving anything else. And we're going to hold it for 5, 4, 3, 2, and down, and switch. Try not to move anything else. And hold for 5, 4, 3, 2, and 1. Down, good. Next one, another good core exercise for the external obliques and the QL is go ahead and bend your knees and almost try to extend your hips so that you feel like your knees, hips, and shoulder are all in the same line. And you're going to bend your knees about 90. So here we have a short lever side plank, hand at the hip. I'm going to hold here. So I'm going to bring the hip off the ground, tuck the chin, and hold for 5, 4, 3, 2, and down. I really want these knees bent 90 degrees. So bend those knees all the way back. Yep. Almost like you're doing a leg curl. Yep. So let's do it one more time. Up, hold, inhale, long exhale, and down. Good. Switch side. So extend those hips. So I don't want to be in the fetal position. And then hand at the hip. Now you'll notice that I'm trying to square my head off. I don't want my head here, 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 or here. I'm trying to tuck my chin as if I was standing up tall. So I'm trying to tuck my chin, and then once I get into this position, inhale 360 through the nose, and then long exhale. As hard as you can, exhale. One more time, inhale, long exhale. Good. Now, then you can go into an advanced long lever plank, just like that. Or you can go 1 foot over, so you get an abduction on this hip and adduction on this hip. That's a really good way to target both abduction and adduction of the hips, is by going to do a side plank. You can put a pad between the knees when you're doing side planks to get more core activation of your adductors. And the side plank is going to be a really good exercise for your QLs and your external obliques. Okay?
I have a question. What does it mean if your QL is tight, or if you feel it on your squats?
So your QL is tight. It just, is it right side?
Yeah.
So right side, most people in PRR standards, they would say the most QLs, because remember that right side is breathing in so much, so we're laterally flexing on that left side a lot. So you have to think of ways to get out of this laterally flexed right position and into this left laterally flexed position. So maybe biasing your warm-ups toward rolling this right side a little bit better, maybe going into those diagonal pattern reaches, maybe doing things like side plank as well before your lifts might create a little bit more proprioceptive nerve input before you kind of go down into your squats. Because when you're squatting, the load is on is it back or front squat? Both. I mean, once that load is on that spine, your lower back and spine are doing everything it can to stay stable. And so this is your stability. And if this is a little tight or a little off, you're really gonna notice it during your squats. So, I mean, I might advise either maybe going to a goblet position. Maybe that will take the load off that spine in that area, and just going super heavy loaded goblets if you want to do that, or going to like a one leg squat where it's so hard to load that much. Plus you're working on actually strengthening it. So you might work at it 2 ways. I wouldn't have you be doing stuff like this though.
That's what it's told to do.
Yeah, even though it feels good, rotation of the spine at the lumbar region is more risky than beneficial, according to research. And I can send you that article on someone who did a study on this stretch, and this stretch. Okay, I used to do all those stretches. Believe me, I did everything wrong for forever. So I know, I thought this was awesome, at the end of my yoga classes, I would just hang out here, but I never thought my back was feeling better. I never thought I was getting stronger there. It's like rotating my neck and expecting my neck to feel better. The same thing for your lower back and knee. People just think that your spine is supposed to twist at the thoracic spine region. So you have your cervical, thoracic, and lumbar. They're all different. That's why when we went over the quadruped T-spine rotation, we took the lumbar out of the equation. Okay? Same thing if I go to a wide pyramid rotation. I'm taking the lumbar out. Okay? I do want rotation of that thoracic spine, just not as much in that lumbar spine. Okay? All right, let's head out back to class. I might be able to sneak in one last clip before we head out today. But you'll probably definitely want to at least go over these PowerPoints and videos when you have some time. We're going to go over, I think this one isn't too long. Definitely 5 minutes. We'll go through the first.
In this lesson, we will examine the impact of physical activity on
I forgot my
skeletal
water
and
today.
mental
Hopefully you have
health.
water, so make sure you drink water.
Let's begin with osteoporosis, a progressive disease that results in a reduction in bone mineral density and severe deterioration of skeletal tissue. Bones become frail and brittle, which greatly increases the risk for fractures, especially among older adults.
So foam rolling could actually, if someone had osteoporosis, you might want to shy away from things like foam rolling. Or even like the half kneeling thing, because of the bone structure.
Common fracture sites include the hips, wrists, shoulders, and spine. Osteoporosis is more common among women, as they tend to maintain lower peak bone mass, experience additional losses following menopause due to a reduction in estrogen, and have an increased risk for inadequate consumption of calcium and vitamin D. Risk increases with age, as everyone experiences a relative reduction in bone mass following the age of 30, and a further reduction occurs after the age of 50. Appropriate resistance training and proper nutrition, such as adequate calcium and vitamin D intake, are keys to limiting one's risk for osteoporosis. Exercises that load the axial skeleton and create adequate bone stress best maintain healthy bone mineral density. Just like muscles, bones need to be used to maintain their integrity over time. Exercises such as the back squat, deadlift, lunge, and military press fit the bill for reducing risk. Of course, all loading and exercise stresses must reflect the extent of the disease's progression. Safety is always the #1 consideration when working with any client.
Yeah, would I load a back squat on my grandma? Probably not. I might have her try some chair supported squats first. I probably wouldn't even think of back squats, but what they're saying is that squatting and those compound lifts with all those muscles, that increases bone mineral density. So that's all we're going to get to be able to go over today. So make sure you check out that first module on your own. We'll be getting into modules 2 and 3 next week, and we'll see you all on Tuesday. No. Yep, just Tuesday. I'll send a reminder email today too.